interested in.
Hi, good morning, everyone. Yes, so I'm Lorenzo Gordon. I'm co-founder and director of Maldaba. We're a digital solution firm focused on the public and not-for-profit sectors, based in London, been around since 2002, and also a director of Tech in Care. So I work with Jess and Irene. I'm very much focused on how we can take technology, which I still think is amazing, and it kind of just fills me with wonder every day, but actually use it for public good and to improve things, to work with people, because we know technology is just an enabler, it's just a tool. What we really want to do is work closely with people in areas like health and social care and see how we can help them do their jobs better, because that's all people want to do every day, in my opinion.
Fantastic. Yes, I completely agree with you. I think we're moving more digital now, aren't we, than ever. So really, really happy to have you on in this conversation and bring your perspective. Lee, do you want to introduce yourself? Tell me a little bit tell the team, the room about yourself.
Hi, good morning. Yes, I'm Lee Fermandel. I've been in adult social care and children's social care actually for nearly 30 years, for a long time. Social worker by background, but worked as a consultant in social care and health for the last 12 years now. And so worked in a number of local authority, health authority areas. And what interests me? Well, I live in a digital world, and every day I interact digitally with people and services. And what strikes me, having heard what you just said, Lorenzo, is that in social care, and maybe in the public sector generally, we're a little bit far behind. We've got a bit of catching up to do. There's a lot of potential there. There's huge potential, I think, in social care. I think that COVID taught us a lot of things, and it taught us we can work differently. And support people effectively with technology. So that's my area of interest, and and I'm very excited about the future, particularly around health, social care, and technology.
Fantastically. Thank you so much for joining us today. Really excited to have your perspective here. Hugh, do you want to introduce yourself and tell everybody a little bit about you and what you're interested in?
Hi, morning all. It's good to hear two Welshmen on the call in following on with each other. So a bit like Lee, really. I've had a long career in public service, mainly in the health service, but also working in charities as well, and more recently with Lorenzo and others in digital systems. I'm one of those weird people that I was a director of commissioning who designed a care pathway series for people with heart failure using digital. I was then the first person to use the technology in the pathway that I just introduced for people with heart failure and East Riding. So I have a commissioner and a patient perspective, but I also work with companies that create digital systems. So I have a bit of a weird background and understanding as to what goes on. And I'm fascinated by really a couple of things. The first is, how do we get patients and carers fully engaged in using digital as an enabler for better care? That first and foremost is a major issue for me. The second one is that I'm really interested in systems, complex systems and complicated systems, and how do we bring digitally enabled care as an innovation into the reality of what people face on a day-to-day basis. And I'm also really interested in how do we shift from using data to using knowledge, and how can we allow the data to create the knowledge?
Well, I think we will come across all of those and more, Hugh. So thank you for that. Hopefully we answer some of those, or attempt to answer, or look into explore some of those questions. So thank you. Really excited to have you here. And last but not least, Amanda, tell us a little bit about yourself.
Hi, I'm Amanda Powell. I'm the ICT and Business Transformation Lead for Adult Social Care in Wakefield Council. Like Lee, I'm a social worker by trade, being a qualified social worker for over 20 years. started my career working in the hospital team, and then I've moved across into various roles since. So my interest is around enabling those people who work on that front line in adult social care to do their jobs, so they can use their time in the most efficient and effective way and support those people efficiently and effectively as well. So those on the receiving end get the best service that they can in Wakefield, that our processes and our systems don't hinder or get in the way of them doing what they need to do. And also, a little bit like Hugh said, it's around data and the fact that we're moving closer and closer to working with NHS partners and other organisations in social care. And again, how can we use what we've already got, or what can we develop further so that that doesn't impact on those on the front line, that we can get the information and the knowledge that we need without having that negative impact.
Fantastic. Thanks, Amanda. Really appreciate that. That actually leads us into the conversation now. And my first question really is for you, Amanda and Lee. We titled this panel, this webinar, about winter pressures, and we all know that we're in them right now, don't we? But do you feel that the rhythm of winter pressures has really changed in the recent years? Do you feel like that we have shifted out of that and it's a continuous kind of cycle? What are your thoughts around that?
Do you want to kick off, Amanda? Go on.
So, as I said, I started my career as a hospital social worker. I came to Wakefield on a 3-4-month agency contract over winter pressures, and I've never left. So 20-some years I'm still here. But yeah, very much it was the October through to March period that was classed as winter pressures. And I don't think for many years that we've had a winter pressure period. I think there's pressures all year round. There's different types of pressure for different reasons, including environmental, etc. But I don't think we can say that this period within a year causes us the most headaches or the most pressure and the most demand on our resources and our services anymore. And that's coming from my perspective up in West Yorkshire.
Yeah. I'd like to add to that. I mean, I think it is an ongoing pressure now, isn't it? People are living longer, which is really good, but also with chronic conditions and multiple chronic conditions. And I think that the complexity these days seems to be much greater than it was. We now talk about medically optimized. It's not the same as medically fit. And we know when people are, for example, discharged from hospital to wherever that discharge destination is, those needs and sometimes comorbidities and chronic conditions are sometimes quite significant. We also know that social care plays a really key role in supporting people, to maintain independence at home, but also to support people out of hospital and relieve some of that pressure on the NHS, but with the backdrop of significant funding challenges over many decades. So with all of that in context, surely it pushes us into what other solutions are there and what does digital offer us in that whole system approach.
Absolutely. I couldn't agree with you more, Lee. And Amanda, it definitely feels, even from a digital nursing perspective, that we are in this year round, aren't we? So what do you think, if you had to discuss an impact on this related to technology, what do you think that impact is, Amanda?
I think it's key that all organisations who are working on that front line and involved in supporting people, be that in hospital or out of hospital, have got access to the right information at the right time. I think that's quite critical. There's a lot of time wasted with people ringing different organisations, different agencies, trying to find out a key piece of information or even the location of that person as well. And all that leads to delays, it leads to inefficiencies and poor service delivery as well. And it is not a good outcome for that individual when they're particularly in crisis situations, as often people are, particularly when they approach social care or NHS services, that they're in the midst of a crisis. So having a shared platform or having access to key pieces of information via a variety of formats, it doesn't have to be shared systems, it can be shared care records, etc., or some other mechanism that allows people to be able to monitor what's going on for that person at that key time. And I think that's quite pivotal, really, particularly in frontline practice and in the midst of a crisis.
Absolutely, absolutely. I couldn't agree more. It's talking about creating those improvements, those efficiencies, that improved care. Hugh, what is your take from your health experience and your background around all of this? Oh, you're on mute.
So it's a very complex picture, and complex things need great leaders to be able to get us through the challenges that we have. But it also needs a good version of the truth that all of us believe in. So I think that the better data that we have, the better information we have, with an understanding of the definition that is of what that data is showing, is really important. And just listening to Amanda and Lee, one of the things that really strikes me from a health perspective is that we need to get those definitions as to what the data is showing right, because people in different disciplines and different organizations use the same word but to mean different things. So Amanda in the recent bit was talking about crisis, whereas in health we talk about emergency. And does it mean the same? And we just need to make sure that across the organizations and across the professions, we get the definition right as to what we're talking about. Because too often we go down rabbit warrens and it's the wrong place that we're going.
Absolutely. I couldn't agree more. Does anybody else from the panel want to come in on that?
Just to say, in the context of sharing information, one of my frustrations has been multiple systems not talking to each other, different versions of truth, never up to date. And when you've got a patient or person flow situation, you never know quite where that person is, because the data is only as good as when it was inputted or read or whatever. So having that one version of truth, as you said, Hugh, is absolutely essential, and a common language, as you say, and understanding the information. But that, I guess, challenge between primary care and primary care networks and your GPs and all the others that work wonderfully in primary care and secondary healthcare. And surely we can find a system. The technology's there to join that up and have really good intelligence to support people within that whole system, whether that's elected into hospital, non-elected into hospital, and tracking through, so we can better, as a whole system, using technology, using digital, using good information, support people much better in a much more timely way and reduce the demand, particularly around beds. It struck me in London when we were focusing on pathway 1s, 2s and 3s. There were lots of pathway 0s in there. They weren't looking at them, but they were in beds. I mean, this is where technology can help us to track, monitor and make effective use of resources.
Absolutely. Couldn't agree more with you, Lee. And that's also just about keeping our aging population independent, isn't it? So the quicker that we get them out of hospital, the quicker they're back in the community. We know we lose those risks for deconditioning and all of those other nosocomial infections, things like that come up. So it's about sharing that information that's really, really clear and is saying the same thing. We know that technology's out there, and we know that it exists. What do you think is hindering some of the adoption of that technology, Lorenzo?
Right now, I think it's just one word, it's capacity. It's capacity within organisations such as local authorities, primary care, secondary care, community services, care providers. Over the last 12 months, I've lost count of the number of projects we've worked on, or the number of people we've worked on who get the implication of the solutions and the services we can offer, and they want to go ahead. And it's often not even a budgetary issue, although we know that, you know, finances have been stretched like never before, certainly, you know, not for the last 25 years, but actually that isn't the primary issue. The primary issue is that organizations do not have the people within them at the moment, do not have the resources to implement change. And it doesn't really matter how enthusiastic people are. Staff are so stretched, they're so overworked that it's all that they can do just to get through the day. And so increasingly what we as a provider are starting to realize and trying to respond to is saying, well, how can we help with that? You know, what additional services can we provide to do as much of that legwork on behalf of councils or hospitals or GP services, because they want the solution and they get it, they just can't implement it.
Absolutely. Yes, that makes perfect sense. And from a you know, a health and social care perspective, Amanda, is there anything that digital suppliers could do better to support that adoption, to support the staff, or do you agree that it's one of those, it's purely resourced and it's a tough challenge to overcome?
It is capacity, very much so. I totally agree with what Lorenzo said. And because of the capacity issue, and as we've talked about, the all year round demands on services, even though people may not be happy with the way that they're doing the jobs and the systems that they use and the processes, they know how to do it. They know what they need to do, what comes next, what goes where. So bringing in a new solution, which we're saying will look like, you know, this blue sky wonderful solution, sets fear into people that I'm just so busy right now and I don't know how to use that system, and that's going to take me longer to do my normal day job, that I just can't do that. I can't afford to work in that way. So therefore I'll carry on doing what I'm doing, even though I know it's not the best way of doing things. And that's incredibly challenging to overcome. There's also custom and practice and the way that people work and resistance to change in there. And I think to answer the question you asked about support from suppliers is being open and honest with each other that yes, this is going to be very difficult. This is going to be very challenging. I think we need to be clear with the people who are using new systems, new approaches, that those first few weeks are going to be quite bumpy, quite rough. Things probably won't work in the way that we expect them to work. We have to configure things, we have to develop it. And I think that sometimes doesn't get communicated or communicated properly, as people expect to switch it on, to follow a step-by-step guide, and it works as it should. And we all know that that doesn't happen in reality. But I also think having been open and honest with people about that can instill that fear even further. So it's managing the fear and letting people know that that support is there. But again, for me, it's about planning the project and the resources that you're going to need to be able to deliver it. And that includes implementation and thinking about, do we need to be taking people off their day job to become super users of the system? Can we get some backfill so that there is somebody else to continue to do the day job? And I don't live in cloud cuckoo land. I know resources are very stretched. I do this day in, day out. It is my job. But if we've got some buy-in from the end users on the shop floor who can then support other people with understanding what the difficulties are and why the difficulties are there, and that give it time, and we will see those improvements in the future. And I think that's the way forward. It is that planning. It's considering what you're going to need to do and being realistic with senior leaders as well, the senior leadership team, about what it is resource-wise that needs to happen. And yeah, definitely communicating that it will be a bumpy road to start with.
Jess, I think that, and Amanda, I think there are some really interesting things in what Amanda said then, around communication with the front line and being truthful and open and transparent about the challenges that lie ahead. But I think one of the main things that I come back to is that the kind of people that we're working with, and it's making sure that we support the people who are early adopters of new technologies, new thoughts, new systems, people who are the real system leaders, and how the technology company as an enabler can support those people in taking risks and giving cover to the people at the front line and taking risks about implementing these kinds of new softwares and new systems, because it's the system leaders that will create a vision for what the plausible future may be with the use of this technology. And that plausible future is quite often the vision that allows frontline staff just to keep trying, keep making the effort, keep understanding and learning from whatever error appears to have happened. And it's that determination, that creativity, that leadership that gives people the permission to do these things differently.
I think also, just to add to something Amanda said, is, and it is getting better in this regard, but it's very, very slow, is a whole system approach to implementing these systems. So a lot of what we do around providing systems that support vulnerable people necessarily involve us implementing them in a social care setting or in a community setting. That means that because of the way things are structured, those are the places that we're going and asking for money. We're asking those people to pay for it, when everyone knows that the benefit is most likely to be felt from a whole system approach further downstream in health. And actually, there is something around getting that better joined up about health acknowledging that and paying for these things in community situations so that health can benefit from them. And that's a difficult one to discuss when it comes to procurement, because existing procurement systems are not well set up to facilitate that. It is starting to get better, but it is a slow process.
Yeah, if I can I pick up on that? We've got time to pick up on that, because you're absolutely, I think you've picked up on everything I was thinking, and about leadership. There is something about total transformation as well, isn't there? Because we, trying to add something to an existing system doesn't always work. And that's when they give up and they carry on with the systems they know and they feel comfortable and confident in. But I'm guessing in this world, as we're pushing more to integrated systems, we've got ICBs that are still trying to find out where they, how they work. That whole transformation piece, that whole skills, knowledge, development bit around tech, digital, I guess it needs to be in those spaces as well, isn't it? In the ICBs, in those discussions, because if we are looking at a whole system, and I remember being in London, the problems I was having, we wanted something, health wanted something, but we weren't, again, coming back to what you said, always talking the same language, but we knew what we wanted, and it was trying to join all that up, and that was some of our barriers. But yeah, absolutely. I think in the context of ICBs and at that very strategic level and getting that leadership right and pushing at it, so it becomes what we do in everything we do, rather than something that's there. It's nice to have, but not sure how we're going to use it.
Yeah, absolutely. Though that's a fantastic point as well, Lee. And it kind of speaks to the issue you can kind of see emerging in different organizations, where when it's a cross-organizational challenge, it's not spotted quite as well, is it? So one organization can kind of spot the issues that they're having, another organization can spot the issues that they're having, but when you have this cross-organizational arrest, especially around moving people out of hospital, reducing admission avoidance, care in the community, that kind of thing, this whole kind of sphere that's very, very much so involves multiple organizations, you know, spotting those issues that will arise for everyone is still a bit of a problem, isn't it? And is there a way that taking data from different places can really help this? Is there a way that could be supported more?
I think that the challenge, and one of the interesting things that we've come up with recently, is that because people aren't meeting face to face quite as often as they used to, some of that creativity and sharing across the silos, professions, disciplines, and between strategic, operational, and tactical delivery, because that isn't happening, some of that sharing isn't occurring. And I think that digital can become a real place where some of that sharing could take place. But it does need the effort of system leaders to bring the discussion together, so that system leaders not only need to tackle the complicated problems that need a linear solution, but they need to bring together people that can discuss in, I would argue quite strongly, in an appreciative inquiry kind of way, to actually drive the improvement. It isn't saying, you know, not saying that isn't going to work, but actually encouraging good ideas, encouraging innovation, appreciating that problems are happening in one sector, and seeing how they can support that in developing those creative and innovative discussions. Because that's where real problem solving in a complex system, that's where it happens. So it's about bringing those arenas together where discussions can take place.
And I totally agree with you, Hugh. And I think that's one of the challenges in itself, is having the right people around the table, be it virtual or in person, to have those conversations. And without that, conversations can take place, but action doesn't. And you need both.
Absolutely. And if you were going to bring, so you are all, I would consider you all to be senior leaders in the organizations that you work from. You know, if you were going to, you know, for Lee and Amanda, what has been your experience around trying to do some of that cross-joint, you know, cross-organization work? Do you feel that those conversations have been happening more in the recent years? More now than before, or do you feel that there's still kind of a hindrance there to get those conversations going?
Who's going first? Yeah, so I think there's more conversations happening, particularly over the last few years, with our partner organisations, particularly in the Wakefield place, with the ICB and other organisations. But again, I think it still can be quite challenging when every organisation's got its own agenda, shall we say, its own plans, its own priorities and strategies to work towards, as well as working towards the joint one that we're required to do. And I'm not always sure we have the right people around the table. So again, we have conversations, but action doesn't follow. And I think that can be one of the frustrations, that everybody's in agreement, but then it dies a death really in there. So yes, there is an increase in wanting to look at how we can do things jointly to bring things closer together, so that we can have the shared information, etc. But I think there's still a challenge in making sure we've got the right people. Yeah,
absolutely. Lee, did you want to comment?
I think one of the issues about the right people is that the organisations change and tinker around so much. So even with the ICBs, as Lee said, being in place now, they're in that process of reorganizing an organization they only put in place a couple of years ago. And sometimes it's very difficult to find who or where the system power actually sits in the debate. And as Amanda was saying, this thing about, is it one vision? Is it three different visions? Quite often we've got too many, and we need to try and see how we can pull them together. And that needs us all to understand and accept where the system power lies.
Absolutely. Yeah, it's a bit of a coincidence that last week I was in a meeting discussing in the West Midlands, discussing a system that has been developed over the last 3 years. It's about sharing information, health, social care. It was originally designed for safeguarding, in terms of the safeguarding adults arena, and going into that meeting 3 years in its development, and people have changed, organizations have changed, evolved, and there was clearly a lack of leadership, because we've got this really good system. It has a lot of capabilities. That information could be used for commissioning. You can think about how that can, all of that potential that information has. And it was clear there was nobody at that point in that meeting actually driving it. So we've all gone away to think, well, who's going to drive this now? And yet that's been going on for 3 years, because those leaders that were there, that were pushing it, have moved on. And those that commissioned it and was the responsible officers have moved on. And so these things drift. But absolutely.
There is something about ownership there, isn't there? When we talk about getting all of these groups of people together, and I take your point, Lee, about when talking about ICBs and ICSs, which are still trying to learn and find their feet, whilst they're also already being asked to restructure. But part of what we've experienced is, if you do get all those people in the room, exactly as you and Amanda have said, there then isn't always that ownership about saying, okay, this is something that as a community, as a place, as a set of organisations representing a coherent group of citizens, we are going to commit to take forward, and there are going to be lines of authority and accountability. And we see that quite a lot, that people are not quite sure these days of their relationships between these organisations, and that accountability gets lost, and that means that ownership gets lost. So either things don't get procured, or they do get procured and they just sit there, like you were just saying in the West Midlands, because nobody's running with it.
Yeah, absolutely.
So that kind of takes us into that idea around, or leads me to think about the idea of how we do engage people and how we do find those drivers and the people who really want to push this forward and make the change. And that just makes me think about co-production. And is that a viable opportunity there? Are there things that y'all have experience with co-production, if you have done co-production before? And what are the impacts and outcomes of taking that to really drive people to help with that engagement? Lorenzo, I know that you have a developer background, obviously. So do you have any experiences around co-production?
I don't think you can be in this world and not have experiences around co-production in this day and age. We've been doing it ever since we started in 2002, although we didn't call it co-production then. And I mean, it's absolutely essential. It's critical. There's that famous Thomas Schelling quote that there's something along the lines of, I'm not going to do it justice here, but it's, no matter how brilliant you are or how skilled and how insightful you are, the one thing that you can never do is think of something that never occurred to you. And that's the whole point of co-production, is to have those voices in the room, to have that articulation. In our case, what co-production means to us is that any project we're working on doesn't just take account of people's voices. It isn't just lip service, but that we are directed and led by those voices. And by user voices, we mean who are the individuals who are going to be using this technology and going to benefit from this technology on a daily basis. So that may be the public, it may be a vulnerable person, it may be families, it may be professional health and care staff or community staff or volunteers, senior managers. And our view is, well, we need to listen to all of them, because if they're the people who need the system, who are going to work with the system, then they're the people who need to tell us what the system is. We know how to do it, but the what needs to come from those individuals. And that's why co-production is basically fundamental to our work these days.
Absolutely.
Totally agree with you there, and it's something very much that we do in our area with predominantly with the social care workforce, very much linking in, finding out exactly what they do and why they do it as well, to understand the way that they work and how we can enable them to make improvements so that they own the changes and the transformation and the progression. So it isn't something we do tough, but we do alongside. So we use our knowledge in like lean methodology, etc., and identifying waste and things, but we talk in plain language. So we work with people where, like I said, we identify what they do, and then we say, well, where do you think the pain points are? What would you like to do differently? And bring them on that journey as well. And we just couldn't do it. We would end up working in a way that didn't work, would be not user friendly, and wouldn't deliver the outcomes they wanted to if we just went in there and implemented something without that co-production.
Yeah, if I can come in on that as well. For many years, one of my frustrations and frustrations of many of my peers, colleagues, has been the systems we work with, which we call, record management systems or client record management systems, which many of them have come out of production lines or some factories or something that might have worked very well for your chickens or whatever they were counting at the time. But when it comes to people, there's huge shortfalls, and I've always had this idea, I still want to see if we can see this through, where we do co-produce, authentically co-produce with those professionals and with people who that information is about the people who use services, and have a really good co-production piece there and create. I know we talk about this a lot about a people's hub where I can access my care account, I can access my information, and behind that there's a professional, and we know those products are out there and they are being developed. But maybe I live in a utopian world, but I'd really like to see a system that really works and joins it up and works for commissioners. So it gives us the intelligence we need when we're looking at our market, joins people with people in our communities. It's not just a case management system. It struck me when we went into COVID lockdown in London, and a lot of the things we were looking at was loneliness and isolation. Of course, that increased amongst a lot of people who were shielding and whatnot. And setting up a service which was an outbound service, sort of reaching out to people. We were finding people on the same street that were lonely and isolated that we could connect. Of course, you've got to think about your safeguards and make sure all those things are in place, but they're on the same street. But our systems don't pick those things up. So anything that pulls that together and co-produces something that, works really well, I'm always interested in.
And
Absolutely.
I totally agree with that, Lee, and go further. All systems, our systems, anyone's systems, to an extent, will do all the things that Lee's spoken about. And if they're done right, if they're properly co-produced, they will really address a problem. No system fixes everything. And this was, it never ceases to amaze me how often I'm surprised by this, because recently we were doing some fairly substantial work in overhauling how reporting and analytics works in our systems. And so obviously co-production, one of the things we did was we went and spoke to our customers and said, well, we've got this opportunity to improve. What is it that you want to see? And one of the things that came out quite strongly was saying, actually, we are using already these other dashboards and analytics systems. What would be great when you're doing this overhaul is if you could pipe your data into this other system, because no single system will ever or should ever try to do everything. I'm very much against this large system. And I think kind of in a way the job at the national level is not to mandate whole system approaches, but it's to mandate the plumbing between those systems about what interoperability needs to look like, and say, you pick at a local level the systems that work best for you to address the sort of problems that Lee was talking about, but you make absolutely sure that those systems will allow that data flow. Because at the end of the day, Lee's colleagues and Amanda's colleagues, they don't actually really care, nor should they care, which system they're using. What they care about is the ability to do their job and spend as little time on a computer system as possible, so that they can do the thing they actually want to do, which is care for people and support people and help people live better lives. And the moment they or anyone else has to enter that information more than once, you know, going back to Amanda's point right at the beginning, that I'm going to shorten just to ringing round, which we're all familiar with, the moment that's happening, something is wrong. And the answer to that is that the information should be doing that legwork, not the people.
Absolutely. I couldn't agree more. And that right there is what you're talking about, is that interoperability piece, isn't it? And it's such a hot topic right now across health and social care, across finance. You know, we're talking about it in all sectors, aren't we? With your experience, Lorenzo, around interoperability and trying to connect all the pipes, what have been some of the barriers to that? And if you could talk to people in the room who are looking at commissioning products and digital and tech, you know, what would you say to them around some of that interoperability piece that you, based on your experiences?
Well, first thing to say is I'm a huge advocate of interoperability. There is no doubt that interoperability is the way forward, and it is the thing to do. We do a lot of that work ourselves, and we always strive to be on the bleeding edge of standards compliance. So in health, that's using technology like FHIR, HL7, SNOMED. I absolutely am convinced that's the way to go. Having said that, I sometimes feel that we're sort of missing the point of it, in that when we engage with potential new customers who are doing exactly what Amanda said, you know, they are ringing round, they're dealing with Excel spreadsheets, there are emails, it's crisis and it's chaos, and it's not fun for any staff. And they say, well, we won't procure your system unless it's interoperable. That's a mistake. And it's a mistake because on day one, it's very, very difficult to demonstrate that you're going to be fully interoperable. In fact, to the point, it's probably impossible. What actually we want those commissioners to be saying is, using your system is better than where we are today. So that's a step forward, and that's great. And what we need in this procurement is a commitment from all stakeholders, including the supplier, whether that's, you know, Tech and Care or Maldaba or anyone else, to say, once you're in with us, you are going to work and you're going to get to that interoperable point, because that's what we want as much as everybody else. But it shouldn't preclude the procurement itself, because if it does, actually, paradoxically, you've sort of done the opposite of what you wanted to do. You've not moved forward. You've not allowed your staff to improve their current working practices. And so you end up with a worse situation for longer than if you acknowledge, well, we need to do this in pieces, because interoperability, for those who don't know, is really hard. I mean, it is really hard at every level: political, administrative, technical, bureaucratic. It's really difficult. There needs to be that commitment, but it can't be the gatekeeper to bringing on board new systems.
Absolutely. And Amanda, have you brought on systems? Are you currently facing challenges of, you know, you're of Wakefield asking for that interoperable piece to be completed prior to coming in, or do y'all kind of fall under that sphere that Lorenzo's talking about, as to work with once the product is brought in?
I think there's questions asked at the beginning about interoperability, very much so that it should. So as Lorenzo said, you know, that is a key question that people will want to know. When I say people, I mean probably the senior leadership team will want to know that it's going to do A, B, and C. But I totally agree with what you say. It's not something that's going to be available on day one. It's part of a bigger picture. And sometimes there's foundations to be laid before we can start building up. And it isn't always the right time or the right approach to do that. So it's I think it's quite critical for certain systems, particularly when you've got the right systems in right areas. And that's just going back to what you said earlier, Lorenzo, about no one system doesn't fit all. It's having the right systems that do the right job for the right areas. But sometimes those need to talk to each other, and there's some critical connections that need to be in place for certain systems, and then there's others where it's a nice to be, or we can wait for that to happen in the future. And it's understanding those requirements. So that's part of our work that we would do up front when we're looking at those key requirements. What do we need on day one? What do we need on day two? What do we need on week 4, etc. And making sure we've got the right foundations and the building blocks to be able to have that utopia view eventually, and know what that utopia view is as well, because that could be quite challenging as well.
Yeah, absolutely. And Lee, in some of your consultancy work, have you seen the same things? Have you seen that barrier around interoperability really play a part in procurement?
It comes up time and time again, and I think it is knowledge and training again, and understanding, what systems can do, what they can offer. And as you said, Lorenzo, sometimes it is having a better system than what we're working with, and then work towards what that looks like, about systems talk to each other and that interoperability. And sometimes that's not always understood. And if commissioners are going out commissioning something that they wanted to do everything, then, as you say, we're not going to get very far in, very quickly. So absolutely, I think it is about knowledge and understanding at all levels.
Absolutely. And that kind of touches, I think, I think it touches on innovation in today's climate, because interoperability is a huge part of innovation and that development and that knowledge and sharing. And, we're in a very stretched environment, aren't we, right now in health and social care? And so, there's a big question of, is innovation possible when you feel like you can't fail? And so, Hugh, from your experience in going in and leading strategy and talking about that change and improvement, do you feel that innovation is really possible right now?
I'll probably say it is possible, but it's also a must. Because the situation that the system is in such challenge that just by doing more of the same, we're going to come across the same problems that we've already had. So I think that innovation is absolutely essential. And we have to, as we've talked about a little bit before, we have to get the mentality and the culture of innovation in the right place. But we also need to have the techniques of innovation in place as well. So the techniques and tools of innovation. One of the fundamental tools of innovation is having good data. So I think, the more data that we have that is accepted, as we said before, in terms of defining what the problem is, helps us make a rational analysis of where we really are, honestly, in terms of performance. It allows us to make some good decisions as to priorities for action, where, one of my old bosses in Department of Health said, if everything's a priority, nothing is a priority. So how can we make some real priorities for making some strategic change, focusing on where the innovative ideas are? But I think one of the things that we often forget is that some of the things that we currently do are not adding value, and so we need to stop doing it. And just an example for me is when I was having treatment for heart failure and using digital systems, I used to put all my vital signs back to the outpatient department and the consultant on a 3 times a day basis. And it used to be all the measures that they would historically have taken at every couple of days in outpatient attendance. But I was passing the information down a digital line. But the outpatient administration system kept asking me to go in for appointments. And so what we need to do is be really clear about what can we decommission, what can we stop doing in order to give us space to do more of the things that are innovative and creative in this system. So we have to do it. We have to be creative. We have to allow those system leaders to encourage that creative environment, bring people together, as we've said before, and focus in on what the real priorities are, and be really clear that good data used as knowledge supports innovation, but don't forget to decommission things that don't work.
Absolutely. No, that is really valuable insight there. And so Lee, I'm going to put you on the spot a bit. I'm gonna with all of your background, you've served a lot of really great areas. Where do you feel innovation is kind of lacking? Are there any areas where it's lacking, where we could really keep our people safe at home, and reduce some of that admission avoidance, or reduce some of those admissions and things like that? Do you have any ideas around what could be done there if you were put your thinking cap on?
Yeah, I think it's about, my personal life and how I live in a digital world, and the advantages and benefits that I get from interaction we're using digital systems, both in terms of time, efficiency and everything else, and information at source. And yet when we look at social policy and the public sector, and particularly social care, we are quite a way behind. And as you said, Hugh, we bring something in, it's almost an add-on. We haven't stopped doing something else, and it doesn't always fit. So it's that whole transformation piece. I think there's lots out there. I think there's lots we can look at to support people when we're looking at our prevention and early intervention and our duties under Care Act, for example, in those areas, which is core things that we could be doing, to support people. And, I love Uber, for example. I just like Uber. I can order something, I can see where the taxi is, I know when it's coming, and it works really, really well. Can a system like that work for care? Can I order my care worker? Can I order I mean, this might be a bit far ahead, but even the technology, when we look at our home care service systems that we procure within local authorities, they're the most volatile systems. I don't think there's any really good systems to help us to manage that, and for people themselves who's using those systems to know when that workers come in, how that the person's gone, they're supported. These systems are used by Uber, and there's a technology there. So can we start thinking about things like that? I'm interested in artificial intelligence. I know there's a long way to go, but AI in social care, carebots, dare I say it, carebots, as we get into much more of the workforce challenges, and we recognise that in health and social care, looking at these opportunities to meet need. I think we should be looking at as part of any tech strategy. And there's thousands of people now at any one time waiting on a list for an occupational therapist to have a look, to determine what low-level equipment that person might need. I'm talking about that sort of cohort of person, a walking frame, a raised toilet seat, a bath board, whatever those independent living aids look like. We know the systems out there, there are SARS and things. Why are people on lists waiting for something that they can get today, tomorrow, and carry on living as independent as possible, and reducing that need arising, then coming back with even greater needs, or ending up in hospital or something else? And and I can go on and on and on about all of those sorts of things, but things that we're using today in our commercial, private life, personal lives, we really need to start bringing in much more into social and healthcare.
It's funny thinking, just listening to your points, Lee, and reflecting on them, that often when we're rolling out solutions, frontline staff will say, "Oh yeah, but we can't do this. This won't work in a professional situation," and gently and sensitively we point out pretty much exactly what you just said, which is that they use Uber and they use Deliveroo, and they've got the online banking apps, so they are already more than capable at using all the skills that they have to do what they do. They just haven't yet quite got the mindset. And this kind of goes back to a point Amanda made a little while back about how you take people with you and how you address that fear. And that fear that staff have is very understandable, because we all put a lot of stock in who we are by our job and our role. And if we see that threatened, that can be very challenging. And so a lot of the work, the human-based work that we do, is around trying to reassure people we're not trying to replace them. We're just trying to help them do their job to the best of their ability, so that they don't have to do some of the things that they shouldn't be doing, and they can focus on the things that we should. And Lord knows, with the workforce crisis we've got now, that's needed more than ever. But it does take time. And it's not just that technology takes time, it's that human behavior change is slow, and we have to be patient and work with it. But I totally agree with what you're saying.
I think there's a real gap as well in how we use technology to support with the prevent, reduce and delay requirements under the Care Act, and that's just following on from what you said, Hugh, exactly. And there are some technological platforms out there that will do it, like the Equipment House, etc., and things like that, but it needs to be more than that, doesn't it? It needs to be a bit more question and answer type thing, so that you know that you're getting the right product that's going to work for you in your current circumstances. Because what you wouldn't want is somebody to get a particular item that then actually causes an accident and puts them in the place where we're trying to stop them getting to. So yeah, and yeah, just thinking about how you go about, if you want to buy a new sofa, you're on various sites, aren't you? You don't go out trailing around shops anymore. You go and you identify what you want and you go to that location for it. And we're not there yet with adult social care, and I think it's a difficult system for people to navigate, and they only want to come to that service when they're in a difficult situation. And again, use the word crisis, when you're in trouble, when you're wanting support and you're wanting it fast, and trying to understand then adult social care and health when you're in that crisis situation is very difficult. It's hard to take on information. People are throwing lots of things at you. And we need to have that advice, that information, that guidance, those types of places where people can visit before they get to that stage as well, to think, oh, I'm having a bit of a concern about my mum when she's getting in and out of bed or getting on and off the toilet. What's out there? What might be able to help with that? And it's not just, oh, buy a bath seat or buy a raised toilet seat. It's like that. Is she having this type of experience? Is this happening? Is that happening? And then coming up with a proposed solution at the bottom, so it's more informed and more interactive, and people get a better outcome, and way before they need to be approaching formal services. So you can do it at a time and when it's convenient to you as well. We're very much a 9 to 5 organisational response, and people have got jobs, carers have got jobs and things, and they can't always take the time off to wait for somebody to answer the phone or I'll come back to you. So we do need to be a 24/7 information service that delivers good information and good support.
And just picking up on that, so I was involved in a piece of work where we delivered, like an Ask Sarah product, we used our own systems to develop something which was a portal that the public could use in order to self-assess or go through a format that would then generate the sort of equipment or type of equipment that would benefit that person based on that needs profile. The advantage with this service, this system, and it did take about 30-odd% pressure away from the OT service, was that the person taking that piece of equipment was a trusted assessor, was trained enough to be able to fit, test, work with the person, and if it was the wrong one, we'll do something else. So those checks and balances were in there. So that was a really good system. And as I said, did take away a lot of the pressure, and quite an expensive commodity when you look at the cost of occupational therapists. And then you could deploy then that resource, that expensive resource, to those people that actually have that level of need that requires that, sort of level of support and assessment. So yeah, so there are ways around that within the system as well that can be managed.
Oh, there are similar systems in physiotherapy, although it's a different kind of area where people are able to use digital systems to do not a self-diagnosis, but a self-assessment. And then with good algorithms, there are very safe, very effective ways of pointing people to the right kind of therapeutic intervention that they can use. And then the professions can send questionnaires out just to assess outcome and impact and progress for people, so that they create some governance processes in there as well. And I think there are some real lessons to be learned, as you said, Lee, in terms of how we can use technology to enhance that self-care, enhance people's involvement in self-management far more than we're doing at the moment.
Yeah, absolutely.
I couldn't agree more. It is about, we know the pressures are increasing with our aging population, and we don't have the capacity to support every single person's care needs. So how do we support them? I think one thing that all of this touches on, though, is the safeguarding aspect. And typically, what can crumble any system outside of commissioning or resources is that safeguarding piece, isn't it? Do you feel, Lee, that there is enough around safeguarding from a development digital tech perspective, or do you feel that more safeguarding work could be done?
Yeah, I think in the areas of safeguarding, I think there's a lot more we can do. We need to think really creatively about what technology can do to support people where there are genuine concerns, where people are living in risky situations or are experiencing or at risk of abuse, neglect, in terms of the safeguarding context around that, and where technology can really come in to support people. I'm still struck with the fact that, for example, I've got an Apple Watch. I'll use Apple. There are other watches out there. But if I had a fall, it will alert me to turn it off. If I don't stop it after the third time, it will send an SOS signal out. GPS, it'll say where I am, and it'll contact emergency services. Now, it works really well. That's for falls, and you can look at how does that fit for people who are at risk of falls. But it could be used for people in domestic abuse situations where there are real risks, because not only if you fall, it would call alert emergency services. You can actually press, and if I hold the button there, it'll do an SOS for me. So technology that's there today, but I don't think it's been considered how it could be used. For example, people at risk in domestic abuse situations, or risk in other situations where actually that device could be the difference between life and death for some, or injury or otherwise. That's just one example. There's lots of other examples out there. Alexa shows. I've got an Alexa show. I like my Alexa show. I drop into my mother every now and again. The good thing is about that, when I go in, I come on the screen. She doesn't have to answer my call. It does give her 15 seconds to get dressed if she's not decent, which is a very good thing from my perspective. But after that 15-second window, I'm in the room with her and I'm having that conversation. We still send people out to do medicine prompts. But we've got the devices out there. We can have Alexa. We can use technology in ways that supports people to be independent, give them a quality of life, less, I guess, in terms of, people coming in. A lot of people don't like people coming in their homes. And I'm thinking of people who, maybe there's the lonely, but also people who may self-neglect and hoard and all of that, and to get past the door, talking to them through the letterbox for something is a challenge in itself. So how does technology support a whole number of people in ways that can reduce risk and manage safeguards within safeguarding plans much better? I don't think we think tech enough.
Absolutely. Yeah, the safeguarding plans themselves, isn't it? That where the digital is not considered, and then the tech is not implemented because it's not considered in the first place, isn't it? And it all actually, to bring everything back into perspective as well with safeguarding and things like that, I think a major key point that we've really hit on here today is around sharing good data and good information. And, one thing that is talked a lot about and papers, the press, is around that risk aversion, making risk averse decisions from people who are on the wards to be able to discharge people out into the community. And you know, the reason why I thought about this is I saw somebody looking at an e-brokerage and PAMs to help with self-funders resolving those issues. We overprescribe care, don't we, so much because we're so risk averse. But if we had information systems to really support safeguarding, to support people with their independence, to share good information, all of those risks and all of that overprescription, we could really see an improvement from top to bottom, couldn't we? Absolutely.
I think silence means yes, Jessica.
Yes, absolutely. Yes.
I know, I had to come in with my point.
I think there's a whole raft of policy areas that, with imagination, we can see how just that core thing about getting better quality data, and we get better quality data by more of us using it. So I think one of the things that we haven't talked about here is this thing that people say, oh, well, the data's rubbish. Well, when the data's rubbish, let's use the data more, and we will all improve the quality of data because we'll keep interrogating it. And it's really important that we don't just give up on the data just because someone says, oh, don't think that reflects reality. Well, let's get things that do reflect reality, use the data more, make it more influential to make better decisions across the piece, because that's a really important element in all facets of care, whether it's in the assessment, the planning, the programming, the operational work, and in terms of what we're talking about today, quite a lot about, you know, just dealing with the capacity issues coming in and going out. Use the data more.
Absolutely. Absolutely. Couldn't agree more. Well, that kind of wraps up our conversation. We've come to the end of it. I'm going to call it quits, cut everybody off. I really appreciate y'all's input, feedback, insight, and discussion. Does anybody from the audience have any questions for our panel members at all? No questions? That's completely okay. Someone asked in the chat, is there a presentation with options around sharing information available? There are, you know, you wouldn't know, but there are a number of options out there. And while I won't run through a list of all of them, we can absolutely put together something to discuss what the options could look like. It really depends on what sector you're in, what you're looking for, what you're looking to commission, or how you want to share information. But I think like I said, one of the key points here is we need to share information more. We've got, you know, great systems in place now to support virtual wards and things like that. But, you know, where are we at with really this keeping people independent at home and safe? It sounds like there's a lot of innovation that needs to continue to happen. And even though we're in really high pressures that last year around, you know, that have been around for the last decade, we need to continue to innovate. So I would challenge everybody in the room to continue coming to conversations like this, continue to having conversations that you're already having around this stuff, and just really staying engaged in this environment, because this is what's going to push you to do something different. Do our panelists, do y'all have anything final that y'all want to say before we close the session?
No, just thank you.
Fantastic.
I think it was a really good discussion.
Yeah, fantastic.
Yeah, nothing from me. It was great to engage with everyone on the topics.
Fantastic. You look like you want to say something.
Well, I'm always a bit of a disruptor, really. I think for everyone that comes, it's great that you attended. Following on from things like this, I used to work for the Modernisation Agency, and I think one of the things at the end of a workshop is just for yourself, get yourself an idea as to what you're going to do in the next 3-4 days. For one person, just really small thing. What are you going to do to improve the service? Just for one person over the next few days. So take it as a call to action about how you're going to use data to improve something. Because actually, if you achieve it, you'll feel really good about yourself.
Absolutely. Absolutely. Yeah, you will get a dopamine hit, won't you? We're all looking for those in today's age. But look, I really appreciate everybody joining today. I appreciate your time. I hope that this discussion has been fruitful for you and has added value to your work life in some way or another. We are all here to answer any questions. If you want to shoot an email, put something in the chat, I'll be staying on for a little bit longer. So thank you very much for your time today, and we look forward to seeing you at the next one.
Thank you. Take care.
Cheers.
Thanks, Jess.
Bye.
Bye-bye.
Bye. Thanks, everyone.